Hello and good evening. I am Dana Donofree. I'm the founder and CEO of AnaOno. For those of you joining us, happy to have you here. Happy to unpack this really important conversation tonight with Dr. Israeli of breastreconstruction.org. I myself, for those that don't know me, am a 15-year breast cancer survivor. To put things a little bit into the mix here, I had a double mastectomy surgery in 2010, the age of 28 years old. I had implant reconstruction, and since then I have undergone a revision surgery to go from under the muscle to over the muscle. And in full transparency, Dr. Israeli was one of my two incredible surgeons, along with Dr. Bank from NIBRA. So we're excited to have this conversation tonight because it's so important that we all understand the risks associated to choices and decisions that are sometimes made in a very short amount of time, especially for those that are diagnosed with breast cancer. For those that are making decisions, understand the risks of maybe a flap surgery to an implant reconstruction to aesthetic flat closure. So all different choices, all different risk factors. And here we are, the one, the only, my amazing doctor, Dr. Israeli.
Hi,
Nice to see you.
Dana.
How are you?
I'm good.
Good.
Um, I can tell you that my first surgery today, I had two cases. My first one was a woman that presented with capsular contracture, and we did surgery to correct that. So it was kind of timely. Of course, I mentioned that to her, and uh, I thought maybe I'll take some videos and pictures in the operating room to be able to share them tonight. Maybe that's more than we need to do tonight, but I can follow up with that. So
Yeah.
yeah, it's a real issue, and people do need to understand risks, but also need to understand, why this happens, and
Mhm.
what are the options to fix these problems. So
So for everybody that's tuning in, can you give us a very quick introduction of who you are, your association and role at breastreconstruction.org and what you guys do at breastreconstruction.org
yeah.
before we dive into all of these awesome questions we got?
Yeah, so I'm a plastic surgeon with nearly 30 years of experience in plastic surgery, focusing primarily on breast plastic surgery, breast reconstruction. And we recently, I practice, by the way, with four other surgeons, so it's five of us that in the group focus on this work at NIBRA Plastic Surgery in New York. But we recently developed a nonprofit web resource on breast reconstruction, and it's still in its early stages. But we're very excited by what we can do going forward in the next months and years. It's breastreconstruction.org. So the domain name speaks for itself, and the mission is to improve education and basically improve outcomes for women who present for mastectomy and reconstruction, primarily through education.
That's awesome. And I'm a huge advocate. You guys are doing amazing work, bringing so much information to the forefront. So, something that happened, I posted recently about, after my consultation with you, about what potentially could be a capsular tear
Mhm.
in my recent revision of about 2 years ago. And what surfaced by me sort of expressing these elongated, potential side effects and issues that you can encounter after breast reconstruction, because we know, it's not easy. It's a major surgery. I just got bombarded with questions about capsular contracture. And, 15 years in this space, 10 years with AnaOno, lots of advocacy. I never even heard of a capsular
Yeah.
tear before. It makes absolute sense to me when you explained it to me. I'm like, yeah, duh. Why wouldn't that happen?
Yeah.
But I think first, like, what is a capsule? And what are the risks, or what is this actual capsule? And what is a capsular contracture?
So people need to understand that a capsule is normal. The
Yeah.
body forms a capsule around any foreign body or any device that's placed under the skin. For example, a pacemaker. A
Mm.
pacemaker under the skin of the chest will form a capsule. Totally normal. It's basically highly organized collagen that forms in response to that foreign body that's under the skin. And it starts to form pretty rapidly after that device is placed under the skin. And it's the reaction of the as I said of the body to that device. You might also, well, I'm sure many people are aware of the ports for chemotherapy capsule. So when we remove the port, there's a capsule that's there, and sometimes we have to remove the capsule or address that. So breast implant, just like any other foreign body, will form a normal capsule. And I did bring
Ah,
a prop.
a
Okay.
prop.
Yeah,
I
I
do
set
feel like
myself
we
a,
are on a Mr. Rogers set. I
yeah,
love the
that's right.
sketch pad, and now we have
Yeah, this is
props.
my
It is
sketch pad.
official.
Yeah, I'm at home now. I'm in my studio. So, but I did write. I sent myself a reminder yesterday in the office, bringing a breast implant because I don't
Fantastic.
just have these lying around at home. Um, but if this is a breast implant, imagine that there's a capsule, a layer of collagen entirely circling this device. Okay, um, the front, the sides, the back. And if for whatever reason something causes that capsule, that layer of tissue and collagen to become tight,
Mm,
that can cause distortion, that can cause pain.
mhm,
Okay. The implant hasn't changed. The implant is still soft. So it's not that the implant becomes
mm,
hard, it's that the capsule around it becomes hard. And it becomes thickened, it can
mhm.
become fibrotic, it can become calcified. Um, and the things that cause this to happen are well, we don't entirely know in everybody or in every
Mhm.
case, but we do know that there are things that can contribute to that. And it's usually any inflammatory process that causes an inflammatory response in the capsule.
So this is
I
really,
can I can draw that. Yeah,
yeah, let's draw the capsule.
yeah. I was going to just draw it just
Yeah,
to
let's
explain it.
do
So
that.
I
Yeah,
know that you asked me if I had. Well, you mentioned it. So
yes. Go,
all
go
right. So
ahead,
if
Mr.
I'm
Rogers.
yeah, this is yeah. So if everybody you can see
We
this,
can see
right?
it. Yeah, looks
Yeah.
great.
So if I'm going to draw the breast after mastectomy and implant reconstruction. Okay, and the back of the implant is going to be muscle in the prepectoral reconstruction because most reconstructions now are done prepectoral. If I'm going to draw the implant sitting on the muscle and underneath the skin, that's the implant in
Mhm,
yellow. If you could see that, what forms immediately around the implant is going to be a layer of tissue that's fibrous, that's the capsule, entirely around it.
How
So you've
long does
got,
it take for that capsule to sort of start developing itself?
uh, well, almost immediately when you put an implant device under the skin, you'll develop a sort of a thin capsule. Its structure is called glycoproteins that will form around the device. Again, normal
Mhm.
response, and it's pretty quick. So at the second stage surgery, even if you do it within a few weeks, there's already a layer of fibrous tissue. Again, normal response. It's when
So
it's
for
when it contracts, that's when there's a problem.
So for people that are going from expander first into implant, are you preserving most likely that original capsule around the expander and inserting the implant then, or does the capsule regenerate itself with the revision surgery?
Yeah, so if you're making the incision, let's say through the front, through a previous scar, through underneath, the next thing you encounter is that capsule. And you cut through that capsule, take out the expander, and then you can use that capsule to your advantage. So if, let's say that the pocket is too big, you can use the capsule with stitches to reinforce it, to move the implant. There's all kinds of things you can do. You can release the capsule if the implant is
Mhm.
malpositioned. That's called a capsulotomy. So yes, the capsule is there. Usually it's normal. Usually you don't need to do anything to it. But if you need to correct the pocket in any way, then that's what you're operating on is the capsule.
I think this is so important because we can see the pictures, right? We see the explant surgeries, we see sort of some breast reconstructions that have gone wrong.
Hmm.
And this capsule is sort of like very visually a little
Hmm.
scary.
Yeah.
And I think what's really interesting here, I'd love to talk about the symptoms because something I hear a lot, and I think it's quite common frankly, because we're patients at the end of the day, right? We're not medical professionals, is will express the concern with my implant got hard.
Hmm.
But what
Yeah,
you said earlier, it's not actually the implant, it's a capsule. So what are
correct.
some of these
Yeah,
symptoms, and
so
how do
yeah,
people know?
so those videos and photos of capsular contracture, of ruptured implants, those are abnormal capsules.
Okay.
Okay, and yes, and that looks scary, right? So they're fibrotic, they're
Hmm.
thick, it could be an eggshell. That is not the typical case, right? Usually the capsule is your friend.
Yeah.
You, you know, it's a normal, soft, pliable, and you can use that as part of a revision procedure. But if the capsule becomes firm, okay, the symptoms can be, just a little bit of tightness. I feel a little tightness. Um, it can become, hard when you squeeze the breast. It can happen on one side, not the other side. It can cause distortion, visible distortion,
Mm-hmm.
and it can cause pain. Right. So, as surgeons, we kind of like to categorize things. We like to have algorithms, right?
Mm-hmm.
So, and when we talk to each other, when we communicate with each other about a patient, we'd like to describe the
Mm-hmm.
capsular contracture. So, we grade the capsular contracture, right? So grade 1 is soft, natural,
Mm-hmm.
normal. So grade 1 is a soft implant. Usually in the patient's chart, I don't write grade 1, I'll write implant is soft, right? Grade 2 is that if it's slightly firm. When you feel it, it's compare maybe one side is soft, one side slightly firm, but it looks normal. You can't tell by looking at it, okay?
Okay.
Grade 3 is it's firm, but it looks abnormal.
Mm.
Okay. And grade 4 is it's hard and it's painful.
Okay.
Okay. So as soon as somebody has pain, it's a grade 4. So, usually for grade 2, we're not going to do an operation. Grade 3, grade 4, that may be surgical. And that's the importance of that of categorizing it. And that's something that we determine on physical exam. There's no X-ray or blood test to show
So
that.
so who's at risk for a capsular contracture, and why do we even know why people get it?
Uh, well, I mean, anybody who has a breast reconstruction with implants, we're not talking about cosmetic surgery here now, but that too. But anybody who has a breast
No, but I think
implant,
it's important.
yeah,
Anybody with implant surgery, whether it's cosmetic or reconstruction, are at
yeah,
risk.
yeah,
Yeah.
yeah. So, it's anything that triggers an inflammatory response. That's the sort of thing to think about. Okay. For example, if somebody who's had cellulitis, skin infection, or an infection after surgery, they're going to be at very high risk
Mm.
for capsule contracture. Okay. If you have bleeding, a little bit of blood in the pocket, right,
Mm.
or hematoma after surgery, then I know that this is going to be a high risk for capsular contracture. Um, Radiation. Okay, so that's a big one, and we can kind of dive more into that. But that's really a huge issue because that causes tightness not only of the capsule but of the surrounding soft tissue. So those are sort of like the major risk factors. I guess if you want to categorize it as it relates to the surgery, you can think about like during surgery, what causes a risk, and you can talk about post-operatively, right? So during surgery, surgical technique 100% can play a role. Okay, so we talk about what's called the no-touch technique. And there are devices now that we can use where we place the implant in a funnel, avoiding the implant from touching the skin. Because even if you prep the skin with
Mm-hmm.
alcohol and prep it, everything's supposed to be sterile. It's not really sterile. It's aseptic, right?
Sure.
So there's still some bacteria there. So you don't want the implant to rub on the skin.
Mm-hmm.
So when we put an implant in, it's like timeout. Okay, let's irrigate everything. I need to put a new pair of gloves on. Okay, let's get the funnel. Nobody's touching the implant. The nurses know. Don't touch the implant. I'm the only
Mm-hmm.
one. I'm gonna, with my new gloves, put it in the funnel and using the funnel, put it into the implant pocket, and then we're done because we don't want it to touch the skin. So if it touches the skin, increased risk of bacteria, increased risk
Mm.
of low-grade infection, increased risk of what we call a biofilm. I don't know if you've ever heard of that, but all these things can then secondarily increase the risk of contracture. And then, as I mentioned, earlier, afterwards, infection or hematoma bleeding increase the risk of contracture.
So would you say you're at the highest risk within a certain amount of time following your surgery, or can capsular contracture happen at any time
Yeah, I mean,
after your
it can,
implants?
yeah, it can happen at any time, but definitely you're going to be at high risk, perioperatively. So if somebody's going to develop a
Hmm.
contracture, in the first couple of months, few months, you're going to start noticing that there's some firmness, and that's when we can talk about, things that you can do to avoid it, things that you can do to minimize that risk. Um, but you can also have somebody that develops capsular contracture, a few years down the line. Okay, and that's when you start thinking, uh-oh, did something happen? So a silicone leak can increase the risk of contracture. Right? So if you have somebody that
Interesting.
presents to
Okay.
you with a contracture 5 years post-op, okay, well, I need to get an MRI because I'm worried.
Hmm.
Okay, you had a tear, right? We diagnosed it as a tear, but it's a clinical diagnosis. It's not definitive.
Hmm.
It's a way to explain how somebody has sudden onset of pain, perhaps after lifting something or exercising, just like overuse of the muscle can cause a muscle injury or a muscle tear or a ligament tear. The capsule is a normal part of the body that can tear too.
Hmm.
And if that happens, usually it heals fine. But if it's a severe tear and you've got bleeding associated with that and blood in the pocket, that means that you're going to be at increased risk.
Yeah.
Which actually just reminds me, when I was a resident, for patients that had capsular contracture, the treatment was
Yeah.
to squeeze the breast super hard to try to break that
Yeah.
capsule. So that was called an external capsulotomy, right? So you'd squeeze it so hard that, some plastic surgeons would injure their thumb doing it.
Wow.
And there was an entity known about, the thumb or hand injury related to that capsulotomy technique. Obviously, that not a good thing to do because
Right.
if you squeeze it hard, you're going to cause bleeding and the
Mhm.
contraction is going to get worse.
So
So
you
that's it.
touched on this just very briefly. Can you explain a little bit more the difference of what tightness post radiation may be for those that have implant reconstruction compared to those that may have a capsular contracture? How do you know the difference, and
Right.
is there something that the patient should be aware of?
Yeah. Okay. So just as an
Hmm.
introduction to that question, or as an introduction to the response to that question, radiation and implants don't mix well. Okay. Radiation is good because it kills cancer.
Hmm.
Okay, so that's important. Radiation is not good because it damages normal tissue, and the effect of radiation can continue over time. Um, Capsular contracture, it refers to the capsule, just the capsule. Okay. Um, Radiation will cause fibrosis or tightening of all of the soft tissue, not just
Hmm.
the capsule. So it'll cause tightening of the capsule. It'll cause tightening of the surrounding tissue. It'll cause fibrosis and firmness, tissue shrinkage. The radiated breast is going to look smaller. So that's a much more involved process than just contracture of the capsule, where the surrounding soft tissue is unaffected. Does that make sense?
Yes, I think that's really helpful. And, something that I wanted to touch on, and actually it's been asked here in the questions, is I know that this sounds silly, but I really want to be clear here because I think what's interesting, especially to those that are deciding about breast
Hmm.
reconstruction after a cancer diagnosis, is flap surgeries, right?
Hmm.
Flap surgeries use your own tissue, but
Yeah,
we're seeing now more surgeries combine flap with implant.
right.
So there's a question asked earlier here, I think maybe even by Baraka Strong, but can you talk a little bit about the flap reconstruction with implant? Is there a heightened risk? Is it the same risk? Is there anything different associated to having a
Well,
capsular contracture?
as it relates to radiation, a flap reconstruction with or without an implant, whether
Mhm.
it's hybrid or flap alone, is going to be a better choice. Okay, so if I know a patient is at high risk of radiation at the time of
Mhm.
diagnosis, my preference is not to do the flap as the primary operation.
Okay.
I don't want to have beautiful, supple, soft, perfect flap and then have it be radiated,
Mm-hmm.
right? Because that's
Mm-hmm.
going to damage that
Sure.
tissue. I'd rather do an implant reconstruction, recover from the radiation, then we'll come back and convert it to a
Hmm.
flap.
Okay.
Um, So if you have an implant underneath a flap, I don't think that the risk is higher or lower having the flap with regards to getting capsular contracture. You can still have any inflammatory response that might affect that capsule. Even if it's underneath the flap, it's similar to an implant underneath natural breast tissue. You can get capsular contracture. Um, you know, my algorithm is if if I can do a reconstruction with a flap, and one of the reasons to do that is to avoid an implant. So it's not that I haven't done the hybrid procedure. Definitely have done that, but it's just I think twice about that. Let's put it that way.
So we got a lot of feedback from just uncertainty and confusion on when, where, what, why. And I think as a cancer patient, right, in some ways we start to get very used to pain and discomfort and a lot of these things that are just involved in our natural life.
Yeah.
I personally have set a boundary. I did not call you until I expressed that pain for 2 weeks because
Mhm.
that is my own personal
I
boundary
see. So it's a two
that
week time frame. I
it
didn't
was it
realize
was
that.
it was at least 2 weeks by the time I called you because
Hang on a
I
second.
have to give.
I seem to remember getting a phone call that was somewhat panicked from somewhere in the southern hemisphere from you,
Yes,
and I don't believe you hit the 2 week time. I
I
think
did
it
not
might have been
because
two
that time I
minutes.
did know something was
I
wrong.
think it was 2 minutes.
We
Yeah,
well, I have to tell you because somebody is also talking about their implants flipping, which we do know might be a part of their capsule as well. But
yeah.
yes, and I almost had a sweaty panic and passed out, believe it or
Yeah.
not. So
Well,
that did
I mean,
happen.
I think that the point you're saying is, how does the patient know when they can call?
Yes.
When
Or
should
when
they
do
be
they know the
concerned?
pain is
Right.
bad enough or the
Right.
thickening is tight enough?
Yeah.
Like
Yeah.
what is that moment that they
I
should
mean,
be calling their doctors to
if you
get checked
feel that
out?
something feels different, look, I tell my patients they can contact me at any time with any concern, right? So
Mm,
if you think something might be wrong, you don't
mm.
know, you have a medical team to help you. So you should just contact your doctor, even if it feels a little tight, because it might not be totally normal or the normal for you, right? And if there's something that can be determined or diagnosed earlier rather than later, then maybe there's some intervention that can help.
Well,
So,
let's talk about that
yeah.
because I think, we had people that had mentioned that they have done self massage,
Hmm.
that they've done PT massage.
Hmm.
Some people have mentioned different prescriptions that they've been put on in order to maybe reduce
Hmm.
their risk or be involved with it. And I don't know if can
Yeah.
touch on some of that, but what would be some of these early interventions
I mean,
that
it's all of the above, right? So, typically massage and physical therapy is first line treatment. Let's put it that way. If you have an early capsular contracture, first of all, massage and physical therapy is important to avoid capsular
mm,
contracture.
okay?
So I tell my patients after
Mhm.
surgery, I'll see them at a week, then I'll see them at a month, and at the 1 month mark is when we review in front of a mirror how to
Okay.
massage the implant. Okay. Uh, and this may not be for secondary procedures because they already have a capsule and I'm not worried about contracture, but when you do a revision, but at a primary operation, it's a new capsule, and I don't want that new capsule to get tight. I want to
Okay.
take every precaution you can at that primary operation. So let's stand in front of a mirror, let's review how we're going to massage. And if it's not me, then my nurse. And it's usually, to squeeze the implant up, squeeze it
Okay.
in, squeeze it down, squeeze it out. But it's gentle massage, and physical therapy is 100%, part of that. So, that can help prevent it. And I do think that in early stages, it can help soften a capsule. You touched on medications. There's what are those medications? They're the
Somebody's mentioned
leukotriene.
singular,
Singular, yeah.
singular.
So leukotriene antagonist, Singular and Accolate, those are two medications. That's been around for many years, couple decades, as a recommended option. Uh, Honestly, I have not had much success with that. The idea is to manage the inflammation around the implant with this medication, but it's a systemic medication. I just haven't seen uniform results with that. And then the question is, if it's bad enough, do you need to do surgery to help with that? And we kind of touched on capsulotomy as a treatment, with with that external capsulotomy, or actually it's not called external. What was it called? Closed capsulotomy. That's what it was called, closed capsulotomy. So, you're not opening the breast, you're squeezing the breast to try to break the capsule. And of course, we've learned that that's not ideal. But if you make a decision that this is enough of a deformity, or causing pain, then the decision is maybe I need to have a surgical procedure. If the patient has radiation as part of the cause of the capsular contracture, I usually want to start thinking about other options, specifically flap reconstruction. If they have enough tissue in their abdomen or thighs, tug flap or deep flap, but very commonly a latissimus dorsi flap in the setting of radiation. That is the you know, old school technique, if you will, and maybe some of the younger surgeons don't utilize it as much. But to me, that's an exceptional option. It was the first flap described for breast reconstruction, and it's extremely effective at completely resolving, reversing capsular contracture, even with an implant underneath. So, a flap can eliminate the risk of capsular contracture.
So I think that this is very important
Yeah.
that you say this because, something that we heard over and over and over again was that patients are going through not just one procedure,
Hmm.
sometimes two, three, four, five,
Yeah.
six, with a constant shift and a cause of this capsular contracture.
Yeah.
So to touch
Yeah.
on that a little bit,
Yeah.
I know this is a very broad question, but should they be asking their surgeons about a latissimus flap as
Yeah.
an option rather than
Uh,
just
you
keep
know,
going in?
Yeah, they can ask their surgeon, but honestly, it's the surgeon's responsibility to bring up the option.
Right.
Okay, so let's just,
Yeah.
that's the
Sure.
truth. So
Sure.
if I have a patient that presents with a problem or for revision surgery, I'm gonna be thinking about everything, and I'll ask them to look at their belly or look
Mhm.
at their back. Even if they're hesitating, let me just take a peek at that. So because we want to talk about that. Also, fat grafting, by the way,
Mm.
is effective, especially in the radiated patient, to reverse some damage. Not quite as effective as a flap reconstruction, but yeah, multiple operations is a red flag, obviously. Then something that, if something doesn't work, if plan A doesn't work, then plan B should be different than plan A,
Yeah.
right? So it's like a basic principle. Um, one of the uh, best things that I've one of the things that I've I've learned over the last 20 years as far as management of capsular contracture without a flap is to just understand the basic principle of what a capsule uh, tear or a capsule contracture is, and how can we prevent that from recurring if just releasing the capsule is not enough. And one of the best tools that I've had in the last couple of decades is using an acellular dermal matrix. From the beginning, when ADMs were used in breast reconstruction, one of the things that surgeons noticed, and one of the things that was reported in the literature, and this is out there, is that the risk of capsular contracture with the use of an ADM is lower than without the use of an ADM.
Mm.
And that is absolutely my experience. If the ADM is properly used with the proper technique, you're going to be decreasing your risk of capsular contracture, number one, in the primary operation. And number two, if you use the ADM in a revision procedure to correct the capsular contracture, you're going to be decreasing the risk of it recurring. Because the number one risk of getting capsular contracture is having had it before.
Oh,
Okay.
okay.
Okay, 100%. So if you have a tight capsule and you release that capsule, you're going to have a raw surface. And that raw surface, again, if this is my implant and capsules all the way around it, if I'm going to take the implant out of the pocket and then release the capsule, that's a capsulotomy, right? So where that hole is, where the capsule was released, now there's raw surface, there's fatty tissue.
Mhm.
Okay. And that raw surface, maybe I can draw this. I think I might want to draw this, because this is important, okay? To
Mhm.
understand. If you, let me see if I can, if I'm in a good position here.
It looks,
I'll
yeah,
just
it
draw
looks
it
great.
on the top
Just use
here.
the middle of the pad. Yeah.
Yeah, exactly. If I go up top here,
Yeah.
right? So if let's say this is and I'm just going to draw the chest wall. That's the breast. I'm going to draw another one here to show before and after the capsulotomy. Okay, so this is the chest wall, and that's the breast with the implant
Mm-hmm.
in yellow. Okay, and I'll draw the implant in yellow again. Okay, and let's say this is the capsule, tight capsule around that implant, super tight. You've
Sure.
got contracture. Okay. If I'm going to make an incision, cut through that capsule and release the capsule, let's say I'm going to release the capsule up top here. So I got capsule on the bottom, capsule on the chest wall, but here on the top here, there's an opening. Okay. So if I'm looking from the inside, what I'm seeing is a raw
Mm-hmm.
surface. And that's what I did today. So today I had a patient contracture. It was definitely tight laterally on the side.
Mm-hmm.
So when I made the incision, took out the implant, I look at the capsule. First of all, the implant, as soon as you took out the implant, you could see that it was squeezed. It was kind of like folded because it was
Mm-hmm.
so squeezed tight, and it even had a fold in it from being squeezed so tight. I released the capsule with an incision, just like this, after the implant was removed, and now That's a capsulotomy. That's by
Okay.
definition an open capsulotomy. So I can just put the implant back in. And then on the OR table, I'll be like, look at this. This is super. It's soft. I've got all this room. I can move it around. It's perfect. And
Mm-hmm.
and that's a legitimate approach to treatment of capsular contracture with good results, but not good
Yeah.
enough. Okay. So the risk of recurrence doing this is too high for me.
Okay.
If you, instead of just putting the implant back in, you take an ADM and you put that ADM between those two ends, replacing the area where the capsule was damaged. Does that make sense?
Mm-hmm.
So now you have a
Absolutely.
bridge, an intervening bridge of the ADM that's going to prevent recurrent contracture. And the way to think about this is, let's say, um, okay, let's say you have a wound in your elbow, like a burn
Mm-hmm.
wound. This is a big burn wound, imagine.
Mm-hmm.
And I just let it heal. I put dressings and changed the dressings, and over time, that's going to contract. It's called a burn contracture. You see
Sure.
that, maybe you've seen patients with chemical burns and their neck is,
Mm-hmm.
that's that. If, on the other hand, I go to the operating room and I take a skin graft and I put a skin graft over that wound, and that soft, supple skin graft heals, well, then I'm not going to get a contracture.
Mm-hmm.
It's not going to shrink,
Yeah.
right? So
Right.
here, if you've released the capsule, and you if you leave the raw surface raw, it might
Sure.
shrink again. If, on the other hand, you take a dermal matrix, which is skin, that's like a skin
Mm-hmm.
graft, and you put it in that capsule in the pocket in the proper orientation as a bridge between where you divided and released the capsule, and that incorporates, that will decrease the risk of recurrent contracture. Okay, so that's if I'm not gonna do a flap to
Okay.
correct the capsule
Yep.
contracture, 100% of my patients who are getting surgery for capsular contracture will have an ADM placed at the
Mm-hmm.
time of the capsulotomy. And sometimes it's technically challenging. If it's way up in the upper part of the breast, I'm kind of standing upside down to try to, reach
Mm-hmm.
to put the stitches in to hold it in place. Sometimes it's easier. But that tool, an ADM, for the correction of capsular contracture, and it's in the scientific literature, is the way to go. So if I have somebody that comes to me with recurrent capsular contracture after prior surgeries, I want to get those old op notes. I want to understand what they had done.
Mm-hmm.
And sometimes that's what I'll see. If, on the other hand, I see that they've had this operation with the ADMs and they still recurred, okay, well, then that's a problem. There's something inherent in their pocket or their capsule, or. that I may not be, I'm not going to be doing it differently or better necessarily than some other plastic surgeon who may be very experienced in breast reconstruction. And if they've already done this, again, plan B should be different. So then we're going to start thinking about, well, maybe you need to have a flap to
Mhm.
salvage this problem because this is a recurring issue. And they've already tried what I'm going to try
Right.
or what I would recommend. So why
Sure.
would I do it again? But there's plenty of times where patients will come recurrent contracture and it hasn't been tried yet. So
So I think this is really interesting. You've touched on flap, you've touched on the
yeah,
ADM. At what point here, with either multiple surgeries or a reaction to the body, do we either the patient makes a choice to explant, right? Because maybe the patient has reached their
yeah,
limits and has understood that, you know what, we're going to
yeah.
explant. That is one scenario, that is one choice, but then there's also the medical scenario, the medical choice to explant. With, obviously the patient's choice to remove the implant, go flat, aesthetic flat closure, always an option. Is there,
Absolutely. And I should have mentioned that,
yeah,
of
absolutely.
course, because
So,
that eliminates the
mhm,
risk of contracture. Yeah,
yeah, absolutely. Yeah. Zeroes out the risk of
right.
contraction.
Hmm.
Is there ever a medical case where that whole capsule must be removed from the
Hmm.
body? And then if that capsule is removed, do they still have an option to reconstruct in the future with potentially a flap, or do you let the body heal, let the body rest, and then, obviously approach different decisions down the road?
Yeah. So the two medical reasons are, breast implant
Hmm.
illness, which is not fully understood entity, and it's a diagnosis of
Hmm.
exclusion, right? So it's somebody comes with these complaints of muscle aches or joint pains and fatigue,
Hmm.
and these generalized complaints. You want to make sure that they've seen a rheumatologist, a
Hmm.
gastroenterologist, a dermatologist. What are all these rash? Let's make sure we're not missing something. And if everything else has been ruled out and there's still
Hmm.
this problem, then you have to tell them that yes, this may be what's going on, and I can't do a blood test to diagnose you. All I can do is remove the implant and the
Hmm.
capsule. The entire capsule has to come out because that's the inflamed process. The implant is not inflamed,
Hmm.
right? The capsule is inflamed. So that would be the scenario that you would do that. Now, if you do that, you're not going to put a new implant in,
Sure.
right? Because you're treating for that problem and you're going to want to see what happens.
Hmm.
You can either do a flap at the same time or you can wait to do the flap
Hmm.
if that's what the patient wants or a flat closure.
Hmm.
But I wouldn't necessarily wait on that. And there are plenty of times where we do a total capsulectomy with an implant removal for that scenario and do a
Okay.
flap simultaneous. The other one is for breast implant associated ALCL,
Hmm.
the extraordinarily rare entity in the case of smooth implants for patients to develop a lymphoma in the capsule. And if that happens, you do have to remove the entire capsule, and that is again a total capsulectomy. That is something that I have done in stages, then do a flap reconstruction, or a case recently where we did the total
Hmm.
capsulectomy and deep flaps, at the same time on the same day. So it's just so dependent on the patient. So, an implant associated ALCL, very rare. Again, in the smooth implant, the textured biocell implants that are no longer on the market, but they're, more common.
Hmm.
But there's still patients with those implants
Sure.
that are being monitored. So if they develop fluid around the implant
Hmm.
or firmness or mass on the capsule, then they require diagnosis with MRI, biopsy, excision.
So Jane just asked a really great question, because this is also my own personal experience. When you go from under the muscle to over the muscle,
Hmm.
and you're able to conserve parts of that capsule, which I believe you conserved parts of mine, and we rebuilt the other
The other
parts, is
part.
that again heightening or lowering a risk of capsular contracture with a revision surgery?
Yeah, no, I don't think that neither. So, if you have a soft, supple capsule at the time of a
Mhm.
prepectoral conversion, there is zero reason to remove the lower and lateral capsule. The only new dermal matrix that you're placing is to replace the pectoralis muscle, which is on the upper part of the chest. So, now your entire pocket, if you had a previous dermal matrix inferiorly, your entire pocket is dermal matrix, and the risk of capsular contracture in your situation, Dana, is going to be very low, right? So capsular contracture is rare in my practice. Does it happen?
Hmm.
Absolutely, but it's not like it used to be, and I credit ADMs for that. And there is a little bit of a trend nowadays to do mastectomy, post-mastectomy implant-based reconstructions without an ADM, and I'm not in that camp.
Hmm.
And you won't be able to change my mind on that. We're going backwards here.
Hmm.
The first implant reconstruction ever reported in the early 70s, and you could see the publication. You can, look at the photo in the publication. It was hailed as an aesthetic triumph, right? But what they did was mastectomy was done, implant was placed, skin was closed. And what developed? A capsule, a tight capsule.
Hmm.
And she developed contracture. So, and you could see it in the photo. I know that if a dermal matrix was used in that case, the risk would have been lower. Right? So
Yeah.
I know that from experience, and we know that from the literature. So I'm not. That's a whole different discussion. But there are surgeons that think that an ADM is not helpful and they don't use it. But then
So
I
it
see them
would
for
be
revision.
helpful to
So
ask. I think it's a
yeah.
great, it's great power with information is power, right? So if you are reoccurring and you haven't gotten a second opinion or a third opinion from another surgeon, these are great questions to ask. I think also, in addition to that, something that we heard was just, um, I believe the largest symptom was pain and
Hmm.
discomfort. Obviously, I'm a bra lady,
Hmm.
and the pain and discomfort. Two questions. One, how long can a patient deal with capsular contracture before it either gets, interferes with their overall health and well-being outside of the pain and discomfort? How quickly should it be addressed? And then also, if they do have capsular contracture, should they be wearing compression bras or no compression bras in order to help with that pain and discomfort?
uh,
In your opinion?
that's individual, and that's
Yep.
is it helping you or not? And so you can make that decision by
So it won't
trial
hurt
and
them
error.
or help them per
Yeah,
se. You
no,
can't apply
but
a compression to make it feel
yeah.
better.
So
Yeah.
capsular contracture is not medically dangerous, uh, but why live with pain,
Right.
right? So I've had patients who've had this discomfort and problems for many years. It's the same thing with animation. Patients that have discomfort, pain
Hmm.
from animation, and they don't
Yeah.
do anything. It's not medically dangerous, but
Hmm.
there's a way to fix it. So awareness is obviously important. My partner, Jonathan Bank, has a particular interest in post-mastectomy pain syndromes. I've learned a tremendous amount from him. I've changed the way I operate based on what I've learned. Uh, every breast operation I do now, I do differently. I think about the nerves. I think about how I manage those nerves. And, you know, it's the same thing with the capsules.
Hmm.
They can contribute to pain. If you don't want to live with that pain anymore, then you should seek evaluation to see if there's anything surgical that can be done to improve it.
Yeah, that's great. And I think it's just so important. We've heard people that have been living with capsular contracture for up to a year, sometimes even over a
Hmm.
year, mostly because they don't want to go into another surgery,
Right.
and secondly, they're just afraid and worried about additional surgeries in their life. So always, forever and always, we will always recommend you call your physicians, you call your care team immediately upon any concern or question with your breast reconstruction or otherwise,
Yeah.
overall health. So to sum us up here, I mean, we've had great questions coming in the chat. We had incredible questions that came through. Uh, did I miss anything?
I'm sure we missed so much. I mean, we could talk forever about this,
Yeah,
right? I mean,
yeah.
I guess if you sum it up, you'd say, well, capsular contracture is certainly a risk with implant-based reconstruction. Thankfully, with the availability of dermal matrices as part of the reconstruction, as part of the revision procedures that we do, that risk of capsular contracture is diminished. Um, if you have a flap option because you have a severe contracture that's grade 3 or grade 4,
Mhm.
distorted breast or painful breast, then you know that a flap will completely eliminate that risk. Some patients are just kind of risk averse. I shouldn't say risk averse, but they don't want to have the recovery, the pain
Mhm.
associated with recovery. But if it's truly an issue, if it's been recurrent, contracture, and they're really having a problem with the implants and their body, it just doesn't it's a problem, then
Mhm.
I tell them, well, you pay up front as far as 6 or 8 weeks of recovery from a flap,
Mhm.
but you're done. So, I feel strongly about that. If you're really having bad symptoms, then look elsewhere as far as options. And if anything happens that doesn't feel right, go to your surgeon. Because there are treatment options. Speak to them.
And I think it's a really important call out because even if you're facing this, you're likely going to a surgeon who specializes in implant
Yeah,
reconstruction and may not specialize in flap reconstruction. So
absolutely.
it's also very important
Yeah,
that they open up the door to either partners or,
yeah,
colleagues of their own, or you seek out a flap surgeon to
yeah.
have a second opinion with.
100%. And so, and I have to say that there are surgeons in my community that when they have an issue with implants or contracture, or they've sort of at the end of the line, that they'll call us,
Mhm.
me or one of my partners. And there have been a number of cases we've done that they'll come into the operating room with
Yeah.
us. They're still with their patient. They want to continue taking
Mhm.
care of their patient, but they don't do flap surgery. Right. So, I think the modern plastic surgeon specializing in breast reconstruction should be offering all options. If they're not offering all options, or if they're favoring one approach over the other, that's not right. It should be just like an open book. When you're seeing a patient, you need to think about all the options that are available and offer those options so that they can make an educated decision. So. I think that that's an important point that you made.
Yeah, 100%. And I think it's just it's the generalized progression of what's available today with breast reconstruction. That was not my options 15 years ago when I was diagnosed. And I think it's also really important to say that we as patients don't have to live with pain and discomfort. You just have to put in the effort to find the right answers and find the right resources. Unfortunately, that is a patient, typically on the onus of the patient. But
Hmm.
I really think that this has been so impactful. You've gotten so many kudos from clearly some of your amazing patients that are very, very happy here in the chat. But really appreciate your time tonight. And if you have any other words to share and embark, on people that are addressing capsular contracture right now and what to do next, what would be those 3 or 5 things that they should get started with?
Yeah, I think that the most important thing to understand is that there are typically options to correct this problem. There really are. And depending on how severe it is,
Mhm.
different approaches. And as you said before, trust your surgical team or your medical team. Don't be afraid to ask them questions. And you know, being armed with knowledge like we're sharing today, I think is important.
Mhm.
You could do your Google search, but that's sort of
Yeah.
in a vacuum. You don't understand what you're reading here. So, hopefully this was helpful tonight.
Well, the illustrations were great. And
Yeah, these illustrations. Yeah, okay.
everybody loves them.
Yeah,
And thank you, Dr. Israeli. We really appreciate it. And if you need more information, please visit breastreconstruction.org.
yes,
If you're up against making decisions on what might be the right surgery for you, or a revision, or further treatment and care, they have so many resources on that website already, with only being a little over a
yeah,
year old,
yeah.
and more to
And
come.
so
So,
much and so much and so much more to come. We are
yeah,
developing a surgeon's corner with upcoming webinars and videos created by surgeons from all over the country,
amazing.
and case presentations, how we think about our approaches. And, a lot of that will be available to individual patients looking at the website so that they can understand step by step how we get people through a primary reconstruction or revision reconstruction or correction of capsule contracture, all of that. So that content is going to be coming up. And if you do go to the website, there is a link for the newsletter, and that could be very helpful
Mhm.
because the newsletter is going to update people with regards to new additions, new content. And this year happens to be the year that we will have our inaugural fundraising gala as a nonprofit organization. I do have to put in a plug for that because we can't exist without
Mhm.
without the help of the people that sponsor us. And proud to say that the Plastic Surgery Foundation has sponsored us. The Natrel has sponsored us. Mentor has sponsored us. So many companies that we work with all the time that have the same mission that we do understand that what we're trying to do is important, and have helped. So
Yeah, absolutely.
yeah.
And of course, AnaOno, we will plug our post-operative recovery garments for any revision surgeries that you may have, as we donate 10% back to breastreconstruction.org as well. So I will put that plug on our recap. And thank you, Doc.
Thank
Have a great
you,
evening.
Dana.
If we miss any questions, please DM us either at AnaOno or breastreconstruction.org, and we will get back to you. And everybody have a great evening.
Have a good night, guys.
Bye.